to this point, we've really talked about healthcare payment systems in particular in a very theoretical way. But what is the evidence that these payment systems matter, and what effects do they have? So there is a relatively wide body of literature in healthcare that demonstrates that payment does matter. And of course, as we look around our healthcare system, the evidence is pretty apparent in a lot of important ways. So for example, we'll see hospital construction in areas that are well remunerated. So for example, hospitals in our neighborhood are constantly building new cardiovascular intervention centers. They're not spending a lot of development money building centers for poorly reimbursed services. So we can see that directly. Studies show the same thing. When payers change the amount that they pay for a particular service, that is, as an economist would say, the marginal payment for a service, we see increases in the volume of that service. So good examples come from instances where we see changes from fee-for-service to capitation, that is, a global payment system, or the other direction. When we reimburse for individual services, we get many more of those services than when we don't. When we say, here's a lump sum payment, you decide how many visits to provide. And likewise, when hospital payment changed from a cost-based formula to one that set a fixed amount for every patient admission, we saw big differences in what was delivered in the context of each admission. And likewise, price adjustments in Medicare are year after year. When we see Medicare, for example, increase prices for certain services like primary care, or decrease prices for other services, high technology services typically, like MRIs, we'll see a big shift in utilization of those services. And these shifts are significant. So if in one example, for example, looking at a change in the reimbursement system for behavioral health, for outpatient mental health therapy in particular, when the payer changed from a fee-for-service system where the provider was paid for every visit to a lump sum payment for every patient that was referred to the provider, we saw a roughly 20% decrease in visits. So that's sort of the order of magnitude that we see going from fee-for-service to a global payment, about a 20% difference in volume. What we don't really understand fully is to what extent that affects patient outcomes. There aren't terrific data looking at patient outcomes in terms of those volume incentives. What the evidence suggests is that it's very mixed. It's not clear that we get higher quality just because we get more quantity. So what do we know about the impact of more targeted payments for quality performance on specific measures? Well, there's a relatively broad literature, some studies from the 1990s, randomized controlled trials in HMOs that showed incentives for immunization, screening, other kinds of process measures had pretty minimal effects. In some cases, small effects. In other cases, reasonably large bonuses had no effect on these process measures. Likewise, in a relatively recent Medicare hospital payment demonstration, the effects of pay for performance were relatively modest, and those diminished over time. So in particular, we see that for hospitals who received these additional payments, they had a small increase in their performance, but the gap between their performance and hospitals that didn't receive these additional payments diminished over time and eventually went away. Even in a very generous pay-for-performance program for primary care physicians in the National Health Service in the United Kingdom, where there's a single payer with a single information system, where you would think targeted quality payments would have the best chance of working, the effects were relatively modest, particularly compared to the amount of money that those physicians were paid. So why can't we get pay for performance to work? When we see that these volume-based incentives really drive the delivery system, why doesn't pay for performance work as well? Well, one thing may be that we're sort of focusing on the wrong thing. So we have these performance measures that we posit are related to the outcomes we want, but they're always a little bit more complicated than that, for example. So we're paying for quality improvement in cholesterol medication, but maybe what we see as poor medication adherence really has to do with something else altogether. It has to do with patient behavior. So we really want to think about the whole complex system. The measure may capture something that is much broader than what the intended effect is, which is really to affect provider behavior. It's also possible that in some cases we're not offering providers enough money to make it worth their while to make the changes in healthcare delivery that would be required to improve care. So a good example here is in looking at hospital readmissions. If we want to reward hospitals for reducing their readmissions, it's going to cost them a lot to improve coordination of care to do that, and they're going to lose revenue from lower admissions. So we need to really think about, are these bonuses or penalties sufficient to overcome the other financial incentives in the system? In some cases, also pay-for-performance programs have been designed in ways that are maybe not optimal. So for example, a payer will set a very high goal that few providers can reach. If the goals are too high for providers to believe that they could actually attain them, then there's no improvement that we see as a result of the bonus. Likely, as we look across the efforts that have been studied in the past, that some of these factors play a role in those relatively modest results. And also, one thing to mention is it's not always clear that providers know the right formula for success under pay for performance. When we focus on outcomes in particular, blood pressure control, for example, the heart failure readmission rates, where these are very complicated factors that determine these patient outcomes, getting readmitted, getting sick, then providers don't necessarily, it's not that they've been avoiding doing something that they know would improve care. They really don't know what to do to make sure these patients stay well and stay in the community. And so an incentive is only as good as the capabilities of the providers that we're giving it to. Empirical studies, just to summarize, empirical studies in healthcare do show that financial incentives matter, and in particular the financial incentives that we're perhaps less happy about these days, volume incentives, really do drive healthcare delivery in ways that are observable and important. And so when payers want to think about rebalancing incentives, that's an important notion that payment matters. As we have seen payers try to target payment deliberately to improve quality, however, there are challenges in the way those programs are designed and implemented that have limited their effectiveness. And over time, payers will learn new methods of measurement and reward that are likely to be more effective. So far, we haven't seen dramatic effects, but we'll see more pay for performance in the system in the future as a result of changing federal policies.